Good morning, everyone. We'll just
Morning.
wait for a few people to jump into the seminar before we get started. Just a minute, that will be great. Everyone holds patiently. That will be grand. Okay.
Give it a minute or two.
Yeah, we'll just give it a minute, let you all join. You should be able to see our cameras. That's Caroline, Angela. Nice to meet you. Just going to wait to 31 and we will get going. I hope everyone's having a good morning so far. You having a good morning, Caroline?
Yeah, wonderful. I've been with you.
Yay, thank you. Right.
Wonderful.
Okay, I'm going to get started if that's all right, everybody. Good morning, everyone, and welcome to B&M Care's Dementia Awareness webinar. My name is Angela Hunt, and I am the Sales and Marketing Director for B&M Care Homes. And with me today, opposite me in our little booth, to present today's webinar for you is our Director of Dementia Care, Caroline Inch. A warm welcome to our existing families joining the webinar today, and also welcome to those of you out there who have been struggling with the recent diagnosis of dementia for a loved one and trying to find your way through accessing further information and support. B&M Care have been operating care homes for 50 years, and with 28 care homes in our portfolio, a new site under development in Milton Keynes, we have a lot of knowledge and experience of caring for older people and especially supporting people who live with dementia. We take the view that providers like us have a responsibility to share our knowledge with our families as well as the wider community. So today's webinar is part of a series of discovery events that we deliver, which includes the Funding Long-Term Care webinar, the virtual dementia tour, and our new Level 1 Dementia Awareness accredited training programme. You can go back to our website, bmcare.co.uk/events for the upcoming dates for those events. So let's move on to today's event. You will see that we have your cameras turned off and also your audio muted. If you have a question as we go along, you're welcome to add it into the little chat and we will do our best to cover these off as we go for you. If we don't reach your question, then we will be happy to respond to you on email after the webinar. We are recording, so a copy will be sent to you within the next couple of days. So moving on to our host for today, Caroline has worked in the sector for 28 years now, starting her career in care homes, progressing to care home management, and then into senior operational and dementia leadership roles. Caroline's got a first-class honours degree in Dementia Studies from the renowned Bradford University and now steers B&M Care's vision and innovation around the delivery of person-centred dementia care. As you will soon see, she is very passionate about research, evidence-based dementia care, and ensuring that all of our residents experience the very best wellbeing whilst in our care. Okay, so I'm going to hand you over now to Caroline, who's going to take you through today's Dementia Awareness webinar.
Lovely.
Over to you, Caroline.
Thank you very much. Good morning, everyone. So we do want you to go away having learnt something. So I'm not too sure if Angela mentioned, maybe she did. This is accredited.
Where have you been?
Yeah, I've been in the pod with you. This is an accredited webinar. So you can, if you're a professional, because I don't know who's joining, you can have a certificate for your attendance today, and that does go towards your CPD. And what we do want you to go away with is having, an understanding of dementia. We want you to understand how we interpret behaviours, and we don't use the term challenging behaviour, we use the term behaviours of distress. We want you to have an understanding of the term person-centred care and how you can apply this at home to support your loved one. And also what's really, really important is how care homes can support positively your journey on dementia. So that's the aims of our webinar today. So I always like to start, and I find it quite useful to give a bit of an overview of the most up-to-date dementia data. So currently in the United Kingdom, we have around 950,000 people living with dementia, and 1 in 11 people over 65 have dementia. There's around 20,000 people living with young onset dementia, and this means that they are under the age of 65. Now, you may have heard of the term early onset or young onset, and this refers to age, not the stage of someone's dementia. A very, very powerful piece of data that really does, impact me in a way. It makes me think about dementia as a ticking time bomb, is that 1 in 3 babies born today will go on to develop a dementia. So we really, really do have to do something about it. And apart from, the hard work that the NHS do, and also research institutes, care homes have their part to play. Now, way back in 2015, the Prime Minister at the time, David Cameron, said that by 2020, we would be the best country in the world for dementia care and research. And, I was going to say 5 years on, we're doing better. We are doing much, much better. But I think there is still a long, long way to go. The last National Dementia Strategy, Living Well with Dementia, was published in 2009. That's like over 15 years ago. So, in government, we haven't had a national paper or a strategy on how we are going to support people living with dementia. So again, just to reiterate, it's really important for care homes, care providers, and professionals in the industry and other institutes to really support and guide families and people on their journey, because it's a very, very, very lonely and isolating illness. So, I find this very, very powerful to understand, the dementia data. So dementia is a condition that affects the brain, and dementia is an umbrella term to describe a number of symptoms to include issues with memory, communication, and language. There are over 100 different types of dementia, but the most common types of dementia that we are used to working with, and largely, the most common, are Alzheimer's, vascular dementia, Lewy body, and frontal lobe dementia. So we're all getting older, and having memory relapses is very different to dementia. Losing your keys is normal. We lose our keys, we walk into bedrooms and thinking, what am I doing in here? However, holding the keys in your hand and wondering what you do with them is not normal. We also find with old age that the language we have and finding the right words is modestly affected by the aging process. And the speed of processing information gradually slows. But again, this is a normal part of aging, and it starts in our 40s. I'm forever forgetting what words I'm finding a tip of the tongue, doing it now, walking into a room and thinking, what am I doing here? So, that's normal part of aging. There are also other things that really do impact our memory. And that could be things like stress, anxiety, poor diet, lack of exercise, and lots of deficiencies that we can also have, such as vitamin D, vitamin B, and iron. And one big thing that's a lot on social media at the minute is menopause, and having issues, and if you're a woman in the menopause, that can also impact your cognitive functioning. In dementia, we also use a term called executive functioning, and this is about processing of information in order to plan, make decisions, and problem solve. And what we find with dementia is that people may have difficulty with their executive functioning. And we often see this when we have residents in their bedrooms getting stuck on certain tasks like washing, dressing. They may be sitting on the edge of the bed. They might have one leg in a trouser and not able to, complete that task. Other examples of impaired executive function in dementia include poor judgment. So that could be around disorganization, disinhibition, and inappropriate behavior. We've often had stories, or we hear about residents, that aren't in our care homes, that have been found wandering the streets at night, or they're found in their bedclothes out in the street, or not even wearing suitable clothing in bad weather, for example. So that's all around that planning and risk management of the way the brain works with its cognitive functioning. So dementia isn't just about forgetfulness, it isn't just about memory. It can affect and impact in so many different ways. So moving on, risk factors of developing dementia are age. So the prevalence of developing dementia is age, but also we have to take into consideration our lifestyle and our genetics, and they all play a part. But there are lots of things we can do to prevent dementia, and we've got to keep a good weight, and we have to think about eating healthy, reducing our stress. Stress is insidious. It's a real silent killer, and it can creep up on you. And we all carry on our busy, busy days and actually don't realize what pressure we're putting on our bodies. And then we increase cortisol and increase, the inflammation in our body. And that brings about ill-being. We also have to keep an eye on our blood pressure and our cholesterol, and we have to take regular exercise. In addition to that, a study in 2022 found that low blood levels of vitamin D were linked with a higher risk of dementia. So we can quite easily boost our vitamin D levels from diet, supplements, or the wonderful thing that we don't see very often in this country is the sunshine. So, we do need to get out in the sun. There are also many other conditions that may present like dementia, but they can be reversed and if treated. So that is something like anemia, vitamin B deficiency, urine infections, feeling poorly, can all bring about symptoms or present like dementia. And these are all really treatable. So what we often find in care homes, that if a resident has a UTI or a chest infection, it can really affect their cognitive impairment, and they can become quite poorly and disorientated. And once we've addressed the issue, which is the infection or the pain, it actually improves them and reverses those issues. So I think it's good for us as part of, our own health to get checked out if we're feeling a little bit under the weather, just to make sure that we're not deficient in anything. So next slide. In this section, I like this slide. I think it's very, very useful to show you how dementia affects the different parts of the brain. And it gives a bit of an insight into how a person with dementia may present and why. In our world, we work under the ethos of person-centered care. So we're trained very differently to, say, somebody like a doctor or a clinician. So we don't place too much emphasis on the clinical element of the disease. More so, we look at the person who's living with dementia, and we look at their social and psychological well-being. But we do need to know the biological element, because it's really important, because then this could also impact how it affects a person with dementia and how they present. So the brain has 4 lobes of the cortex, and they all do things very, very differently, and dementia affects them very, very differently. So the frontal lobe, which sits behind the eyes, that controls our emotions, what we say, what we do, our planning and our executive functioning, which we spoke about earlier on. And then you have the temporal lobe, which is at the side of your ears. And this part of the brain is all about knowledge and understanding, memory, language, and communication. It also controls our inhibition and mood. So if this part of the brain is damaged, it can increase someone's mood swings and disinhibition, which is where we may see an increase in things like sexualized behaviors. And we do often come across this, very rarely, but they are, present in our care homes. So it's really important to have an understanding when people come into care as to, what type of dementia people have. Now, at the back of the top of the head is the parietal lobe. Now, if this is damaged, it affects the process of planning, and it also increases core spatial awareness and bodily awareness, and dexterity and motor skills. Now, if you've got dementia in this part of the brain, that can also affect your mobility and increase the risk of falls. It can also impact diet, as residents may not be able to hold a knife and fork correctly. So if they've got issues with dexterity, they may need an adaptable aid to support them with their eating and drinking. In addition to that, what we find is that residents often bump into things at risk of bruising. Are they on an anticoagulant? So there's lots of factors that we have to take into consideration when looking at the part of the brain that's damaged by dementia. At the back of the head, we have the occipital lobe. Now, it's important to know this because it's about the visual perception. The occipital lobe helps a person make sense of what is coming in through their eyes. And if we have damage to this part of the brain, that will impact the way in which a person with dementia sees their world. And that will impact how they interpret colour, how they interpret shapes, geometric shapes and patterns, and black mats are no good for people with dementia, because with the dementia being in the occipital lobe, it impacts how they see the world. So what we do in our care homes is that we make sure that our corridors are largely plain in colour, and they're a primary colour because they need to have the contrast to be able to navigate. We also try not to use wallpapers or pictures on the wall that are geometric shapes and patterns, because that can bring about hallucinations. So we've developed our own guide, which is a wellbeing by design guide that we use in all of our homes to help our managers shape our environments to support people with dementia, but also support people who don't have dementia, because also the aging eye as well. So dementia does impact in many, many ways, and it's very interesting and important to know how it does impact and affect the brain. So in this slide, we look at notable behaviours and how they may present in dementia. We don't like the term behaviour either, because, you know, again, it's not in line with our person-centred ethos. But we also need to think about, you know, how the psychological and social elements of a person affect how they present. So a loved one with dementia may exhibit a challenging behaviour. So we call these now behaviours of distress, or a form of communication or an unmet need. People living with dementia may exhibit these behaviours because they're trying to tell you something, they're trying to communicate, and they're unable to verbalise what they're trying to say and to express how they feel. And most behaviours of distress may appear to be challenging, and this is what happens when, you know, dementia needs go unmet. So we'll just work through this little slide here. So when a person feels disempowered or they're losing control, they will try and take back that control. They may have moved into a care home, they may be starting on their journey of dementia, they may have noticed a difference in their memory and realised that something is going on. And this loss of control can present in many different ways, and we see it quite often with residents refusing to bathe, refusing to eat, hoarding. We have residents that want to keep newspapers or clocks or tissues in their drawer, and it's just so they can retain a sense of control and autonomy over their lives. They need to feel in control of their lives and keep hold of their dignity and sense of self. So almost like they're telling you no. Mm. We also see a lack of focus, and that's what people cannot sit still, and we call that walking with purpose. You may read that it may be pacing or wandering, which, you know, is seen as a behaviour of distress, but we don't know why they're doing that. So what we look at is pain and discomfort, because if we have a headache or a migraine or a backache or a toothache, we can't sit still. We need to have relief. We need to walk. We need to go and do something. We need painkillers. A person with dementia may not be able to tell you that. In some of our homes, we have just implemented a wonderful piece of technology called Pain Check, and we're trialing it in 6 of our homes currently at the minute, and that's using AI to detect whether or not people are in pain. And we take a picture of a face, and we're able to, the AI technology is able to pull up 9 microfacial muscles that indicate pain and discomfort that we can't see with the naked eye. So that's really proving to be an absolutely, you know, massive benefit to our care homes, because then we're able to then treat people's pain and discomfort. So that's really supporting a lot. So yeah, making sure people have, you know, their needs met, pains identified, discomfort, or reasons why people cannot sit still. Life history is very, very important. You know, is it because they were habitual walker? Is it because they actually never sat still? You know, they were the mother or the father of the house and they'd done all the jobs and they had the children to feed, and, you know, they had the chores to do. So they were up and down, up and down. It could be just part of naturally who they are. What we also have is a loss of peripheral vision. And if we do not communicate properly with somebody with dementia, we can end up with a high startled response. And that could then lead to a resident or person hitting out in anger and displaying aggression. So what we always try to do when we train our staff is to apply the Egan Solar theory, where you always communicate face on, and family members must do that as well at home. If you come from the side, they're not going to be able to see you here. So then you might get a punch or, you know, something, you know, lashed out. So, you know, it's really important that if we do communicate, we do it, you know, head on and very, very slowly, and simple language and sentences, so people can really absorb what you're saying. Another thing we hear about often when we used to do these seminars in person was family members saying that their loved one would shadow them, and that's where they would follow them around the house quite often. And this is largely to do with, you know, loved ones feeling scared or vulnerable. And we sometimes see that in care homes, but what we do is we like to have lots of occupation and engagement, so it kind of distracts and reduces that fear and that need in people. But it'd be quite hard for family members if you're at home and maybe your loved one is shadowing you at home. So it's important that, you know, we occupy people, and even if we do it in care home, we can still do that in our own homes as well. What we like to do is also look for alternative reasons for these behaviours, and I cover that off in our next slide here. So I spoke briefly about pain and discomfort, and pain is a big problem in dementia care because it really does change a person's behaviour. And pain is one of the most common symptoms that people with dementia will experience. However, it is often poorly recognised and undertreated in dementia. And as we know, the main reason for this is as dementia progresses, there is that lack of ability to be able to communicate pain. So pain, I always rule out pain. So if somebody is presenting with a behaviour of distress, the first thing I need to identify is, are they in pain? So rule in or rule out pain. If it's not pain, then it has to be something else. But if it is pain, then you can treat it with analgesia or whatever they have. In addition to that, we have poor health, and poor health can contribute to behaviours in dementia as a result of, like I spoke about earlier on, infection, UTIs, all sorts of different things. And if your loved one has a sudden and unexplained change in their behaviour, such as increased confusion, agitation, or apathy, this could be down to something like a urinary tract infection, chest infection, sore gums, sore feet. So it's ruling out all those physical elements as well. Now, one thing we don't really talk a lot about is low mood and depression. And as well as having negative feelings, if a person with dementia has depression, it can make problems with their thinking and memory much worse. Depression can also make changes to their behaviour worse as well. So they may get a bit more agitated or aggressive, and a person with, you know, depression, maybe because they've got their diagnosis, or again, if we think about loss of control around them, they could be depressed because of the changes that are going on. They could be depressed because they're losing a sense of self. So again, we have to make note of how their mood is, and if they are having experiencing depression. Then we have side effects of medication. So when we think about medication, I'm talking about medication that we refer to as something called antipsychotic drugs. Now, These are used in people with dementia probably too freely, but we've done an awful lot of work at B&M Care where we don't actually readily advocate for the use of antipsychotic medication. Now, they can cause very serious side effects, and what we see is an increase in daytime sleeping, drowsiness, and confusion. They also can cause a resident to shake and become unsteady, which impacts their mobility. And we always say to our care homes, and we don't ever say no to any type of intervention, but we like to work within the framework that promotes person-centered care. And we also like to work within the NICE guidelines. So we've got very, very strict protocols around using antipsychotic medication. I have also seen residents that have used them and that have flourished and lived a very, very good life because they've had their low mood and anxieties in their dementia managed very, very well with medication. But it is absolutely individual. What we also find is there's a lack of life history and knowledge about people, and our lives shape who we are. And for caregivers, it can really help with dementia because we're able to understand who we're caring for, what shaped their identity, what was their life like, what are their issues, because sometimes in the past, people with dementia bring the past into the here and now, and that can really impact how they present. So it's especially useful for the care providers, caregivers, if families share all this wonderful, wonderful information with us before they come in. And we have our own life story work that we do. And what we also find, it helps to encourage better communication, better understanding, and we're able to build much better care plans. So if you are looking to move into care, or you even have home carers coming in, or you're in a home at the minute, speak to the manager, speak to whoever provides your care about ensuring that life history is incorporated into people's daily care notes, because it can really, really support people. I've cared for people that have had the most traumatic childhoods, and they relive these memories in their dementia. And we've got to be mindful of that so we can tailor our approach and tailor our care. One thing that we have been really passionate about and what we've really focused on is the environment. And you can have an over and under stimulating environment, and that absolutely can affect a person with dementia because they will be extremely sensitive to the world around them. So what we say, moderate levels of stimulation, a bit of music, maybe they may want to watch TV, but to have the TV on silent and the music in the background and the clanging of cups and the shouting of I don't know, anything, family member or staff member or anything, it can be all too much. And when we experience overstimulation, we can increase the risk of more confusion and agitation. And that's when we get a behaviour of distress. In addition to that, where there is too little stimulation, we also see people withdraw from the world around them. And that's where we see people in a state of apathy. So with that, you need to bring people out of their bubble, and according to their needs and their life history, what they used to do, try and, occupy and engage, because that will bring about a sense of well-being. So there's lots of different reasons why we see behaviours of distress, but there's also, lots of things we can do to reduce them. And it is about well-being. It's about living well with dementia. Did you want to say something?
I was just going to follow that up really by just sort of covering that, the behaviours that we see in people, is important to recognise that they're forms of communication.
Yeah.
And it's either our approach to the care to that person that's causing that behaviour, or it is the environment that is causing that. They're the first two go-tos to check out, aren't they?
They are.
When we see a behaviour. So okay, that's what I was going to.
Thank you for that. Yeah, very, very, very true. Very true. So there are many things we can do to support our loved ones living with dementia, and we have a few tips to support you at home. So it is very, very hard when you're caring for loved ones in your home environment, because it's you and your loved one, and it could be 24 hours a day with probably family support or a bit of help, but it's very, very hard. We're very fortunate because we have so much training, support, strategies, and you're in an environment where there's a lot of us doing it. But when you are faced with something, one of the questions we also get a lot is, mum or dad or my loved one may repeat questions over and over again, or they may see things that aren't there. And we do get this a lot, and we use something called a validation technique. So what we may have in our care homes is somebody asking for their mum. So what you wouldn't say is, oh, well, mum died 30 years ago, or I want my husband. Well, he's dead. We wouldn't say that. We would turn the conversation around and be like, your mum, you've both got the loveliest brown eyes. That way you're validating about the mum, but then you're distracting away from that need of wanting mum, but you're still talking about mum, but you're just steering them into another direction or away from any negative kind of responses. We have this cliche of go within, their reality and climb into their bubble. And we really should. So the world around somebody living with dementia is very, very real for them. Now, I have got a great friend who I don't talk to enough, but his name is Norman McNamara, and he he's a younger guy. He's in his 50s, possibly 60s now, living with a Lewy body dementia. And he is the founder of the Purple Angel charity. So he's wonderful. And he really does experience the most awful hallucinations. But what is so powerful is that he can talk about it. So we can take what he's telling us and we can apply it to our knowledge, that we get a bit of a better understanding of what people are really going through. So one example from Norman was that he, some years ago with his wife, he lives in Devon, he travelled up to his hometown, I think, to do a talk. And then they were driving all the way back down to Devon, and he said it was if what's that thing?
Curtain.
A curtain, yeah, curtain.
I'm here.
When you're on stage, the curtain comes down. The curtain came down, and his whole environment shifted, and he was back in Bolton. And he said to his wife, Sarah, I'm back in Bolton, what's going on? And she tried to bring him round and said, no, come on, Norm, we're in Devon now, look. And within like 20 minutes, he was out of that. It's like a hallucination. But he doesn't remember sort of like being in it. He just remembered the change of it. So the brain is a marvelous organ, and and when it's affected by dementia, it really does impact people. So we have people living in our care that are having these types of hallucinations. We often hear residents talking about the children. You get that an awful lot.
Yeah.
Children in the cupboards, or children in the room, or the man staring at me. And we have to get the children and the men out. We had many years ago a seminar in Cheshire, one of our homes, and we had some community police officers, and they were talking about an experience they had where a lady called and said there was a man with a gun in the draining board. And they were wonderful because they went and got the man and the gun out of the draining board. And it is just really that. It's like jumping in the bubble and taking this very seriously, because it is so real to them. And if we can just be a little bit more kinder and a little bit more sensitive to people's needs, it goes a long way. What we also worry about is, as loved ones, is having time for yourself. And you actually are the most important people. And you have the hardest job, and your journey matters too. So what we try to do in our care homes is set up groups or networking events, and we're not it's not just B&M. I mean, there's loads of care homes, like 5,000 care providers in the United Kingdom. So, you know, if you've got these resources or care home support groups, go and take time out. Also, there's a lot of dementia support groups out there now, so they're very, very helpful. One of our homes actually in Beaconsfield was talking about some families in the community have asked for a bit of daycare, so they're dropping people off during the day and they're having a bit of dinner and a bit of lunch and some entertainment, and that gives the carer then time to go and do what they need to do, just to take time out for yourself. So you've got to look after yourself as much as your loved one, because if you're not well and you're not fit, then it can impact everything. We've also got dementia cafes, and we've also got our seminars, which we now do as webinars, but every now and then we do events. And I think we've got an event coming up in January in Kings Langley and Shendish. So that's a little bit more in detail. It's a bit of a training program as well. So Angela will send details at a later date if anyone's interested in that. What we also find for people with dementia is that structure and routine really, really work. So familiar routines provide a sense of comfort because it's normal to them. And when we have structure, it will ease any worries and anxiety. So if you've always had tea at 5 o'clock, continue that. If you've always had, sherry in the morning, make sure that happens. Also, getting a good night's sleep. One thing that we see an awful lot, that sleep is really impacted in dementia because there is, such a lot of changes that go on in the brain, and it affects the circadian rhythm. But what we find, if people are sleeping during the day, they're going to be awake during the night. So this is something we absolutely have to be mindful of too. We also advocate for familiar activities, and one seminar we attended, a lady got quite frustrated because her husband was living with dementia and he used to really mess up the filling of the dishwasher, but it was always his job. That was what he did. So we encouraged her to let him continue to do that and to continue things that he would normally do at home, because then that gives him a sense of purpose, and it also resonated with his past and who he was. And then we talk about, that psychological and social element. You're meeting people's, psychological and social needs, as well as caring for the physical as well. Anything to do with changes to routine or anything out of the ordinary can also lead to other areas of confusion and anxiety as well. So it really is just keeping things very, very simple and sticking to routines. One thing as well, we spoke about it earlier on, is about communication, and we do stress that you must communicate very, very clearly and very, very slowly, and not to overload somebody with dementia. And communication can become very, very challenging. So we always say keep it simple and keep it short. Communicate face on, nice, open and welcoming posture. And we've de-escalated so many episodes where people have had, horrible challenges just through communicating. And it's powerful, and it's just about having, kind eyes and a lovely smile and, a comforting touch. And you can, with the, this, just technique, or not even technique really, just basic care, bring people out of all these horrible behaviours of distress.
Caroline, we've got a couple of questions come in, which might be quite nice for the rest of the group just to hear your response to these. How do you deal with feeling guilty if I don't go and see my loved one every day? It's a hard one, isn't it?
I know. One of the biggest things that we do talk to families about is that feeling of guilt. And I would say that you have to look after yourself. And if you can't get there every day, it's easier said than done. You can't beat yourself up.
No,
you really can't. And I think it does help to talk to other people in a similar experience than you, and you can share that burden with them.
Yeah.
Because it's hard for you to go in there every day, for example, and and you're also you're grieving. You've lost a life, you've lost a loved one that, you know, would have been at home with you. So
Yeah, I'm assuming this person is in a care
yeah,
facility of some
yeah,
description, but you know, getting that support from the other relatives and you know the team that work there,
yeah,
you should be feeling some reassurances from them that it's
yeah,
okay when you're not there.
yeah, absolutely. Even you know, to make you feel more, I don't know, comforted, you know, get the home to give you, like Angela said, more updates or something,
Yeah,
you know, show you what mum, dad, husband, wife is
yeah,
doing.
texting you some WhatsApp pictures
Yeah,
of you know what dad's been up to today, that type of thing. Or I would want to feel those reassurances as
yeah.
well.
I always find just talking talking to people in similar situations. When we have our do at Shendish, or when we do a face-to-face seminar, you will be in a room with so many more people who are going
And
through what
those,
you're going
yeah.
through, and you're all going through the same thing. So I find comfort in talking to people.
So
There's
isolating for families, isn't
it
it? It
is,
really is. You know, you feel like you're on your own, and it's hard to come across events where you put in all those people together that you can
yeah,
talk about that. But you know, if you have the network of a care home around you, then you know, I'd be looking out for opportunities to
yeah.
network with as many people in the same boat as you. Yeah.
Absolutely. There's also, I mean, I'm a member of all of the dementia support groups on Facebook, and I often see posts from people that are experiencing the same things. If you do have social media, join a group as
Yeah.
well. But I think it's reassuring when you get feedback from a home or somewhere
Mm.
like that, that you know your loved one's doing
Okay.
okay. And
Yeah. I do have another question,
okay,
and this is from a lady whose husband refuses to go see the GP, doesn't want anyone to know, gets very angry if she tries to persuade him to go see the GP. Have we got any advice for her?
it's very, very similar to a story we had about 9 years ago. And there was a chap who had a very similar experience with his wife. She was in
Yeah,
denial. Do you
yes,
remember?
yeah,
And
yeah,
he was
yeah.
at wit's end.
Um,
Um, have
such
you,
a stigma, isn't there?
yeah. Well, and also because your loved one is going through that change, and he knows that he's going through that change, and he's in denial, and maybe, you know, he's not at that point yet. What we advised is at that time, in the same reply now, that whether or not you could have a conversation with your GP, and whether the GP would come out to the home,
Mm,
because they should really, they should
yeah,
come and support. And I don't know what your loved one would be like in that home environment if the GP is just popping in and just have a general conversation.
yeah,
Is there, you know, is he at a stage where he knows there's changes, and it's just like, look, you know, let's just go and get a blood test, let's rule out that you're not anemic, let's rule out that you're not
yeah.
deficient in vitamin D.
That's a good
um
idea.
because also, if he is or she is in the early stages of dementia, there is anti-dementia drugs that they can prescribe, and they do help. So there's things like memantine and donepezil, and other medications, and you know, they do, for some, or for most people, they do help slow and delay. But my only advice would be to have a conversation with the GP surgery, and to see if there's a lovely GP that would possibly do a home
Yeah.
visit.
Mhm.
Um, but again, you know, I'm more than happy to have like conversations one-to-one with people. It's very
Yeah,
hard to,
yeah. We'll give you
yeah.
our contact details at the end, and perhaps we can help steer you a bit further. Okay. Do you want to
Oh
continue?
yes, I
That's our
do. I've
questions for the
lost.
moment.
Yes, lovely. So take time up, because I'm working my way through this now. So we spoke about communication. Also, as well, what we find families spoke about is the sometimes family residents or loved ones may not do well with eating and drinking. So one of the things that we would always suggest is having adapted cups and plates. Now, what we have is in our care homes, not a generalized approach, because people might like a china mug, but we use a red or yellow plate, because that can also support with the eyesight. So red is a color that it's the first color I think we learn as a child, and we first see as a child. but our eyes are able to differentiate these colours better than sort of insipid or pastel-y colours, and they've been seen to stimulate appetite as well. There's also lots that we can do around the home in relation to positioning objects to help mobility, things that we can do to reduce falls. So having things positioned properly around the home. It's very different. You're at home because you might have your coffee table there and a little side table there and a plant over there. So adapting your home environment as well can also support people living with dementia at home. Light surrounds and taps, to maintain independence. What we do in some of our homes, if it's needed, we'll put a surround around a light, so then you can see the contrast between the wall and the light. That gives independence. We have grab rails and different taps that can all aid independence. And as I said, we move away from things that could be negative in our homes, such as things like shapes and patterns and things that can distort vision. And we do remove mirrors, and we do take away things like black mats, because a mat can be perceived as a whole and a mirror can actually bring about things like hallucinations. We have families that have come to us because they've had a lack of appetite. So again, we've suggested like small portions over the course of a day. Grazing foods that can be picked up, fortified shakes, smoothies, lollies. They all really support people that have got issues with eating and drinking. So there are lots of little things that we can do at home level. And as I said, there's so much information. The Alzheimer's is also wonderful as well for information. So B&M Care community support. So I think Angela was going to actually do this a little bit.
Okay.
Is there any other questions?
Yeah,
fire them away.
You can fire them away. But yeah, community support. So our homes support in different ways, but in your communities, look out for these things so you can network with other people. Memory cafes. We do run some memory cafes at some of our homes, but there'll be a lot of community events going on with memory cafes. Dementia friendly communities, a lot of communities are going for this kind of like badge of honor around dementia friendly communities. So look at what your community is doing. The Dementia Action Alliance group or the Alzheimer's Society can signpost you in those directions. Dementia hubs, Caroline, did you want to talk about that as a project that we're doing for our homes?
Yeah, so we have, well, I'm working on a blueprint currently because we have noticed that families are really, really struggling to place residents with dementia who have more complex needs. And they usually get shipped into a nursing home, and that means they're kind of in a bed. There's that lack of engagement, occupation, and an awareness around the whole person-centered ethos. So we have developed 3 hubs at the minute. We've got Osborne Court in Baldock, we have got the Radley in Borehamwood, and we've got Dalton Lodge in Walthamstow. And these are all lovely, lovely, brand new, beautiful homes that have got their own specific hub for residents who are experiencing more complex behaviours. What we don't want to see is poor people, sitting in an NHS bed for days on end because they can't find a suitable home. So that's something we're looking at, and we're going to have meetings hopefully with the local authority to tell them about
move that forward. But in general, we talked at the beginning of the seminar about the other types of discovery events that we do within our homes. So you can reach out and look for those events on our website. So today is one of those events, the Dementia Awareness webinar. We also run a webinar on funding long-term care, because it comes at a cost unless you are supported by the local authority. We also run a virtual dementia tour experience, which very much focuses on how you interpret behaviours and as forms of communication. And then we have our level 1 dementia awareness training, which is accredited, and we open that up to the public. It is sort of like the benchmark level. All B&M Care staff have this training, no matter whether you're a carer or the cook or the part of the hospitality teams. Everyone has that training, and we offer that to the public as well. But of course, there'll be other signposting events and dementia cafes and things that go on. But importantly, it's that networking bit, isn't it?
Yeah.
Being able to lean on other people in similar situations.
Absolutely.
You can move to the next slide, I think, Caroline, if you don't mind. She's in the control seat. So 28th of November is the next time we'll run the virtual dementia tour. It's going to take place at our home in Boreham Wood. Pop onto the website to have a look at that for you, for yourselves. If you'd like to attend, you can just sign up on the website. It really gives you a bit of an insight on what it might be like to live with dementia. So we use lots of different sensory aids to kind of impair your ability to communicate with us. So how to tell us that you're in pain, not that we're going to inflict pain. I don't want you to think we're doing that. No, sorry, take that bit out. We're not inflicting pain on you, but it will just give you an insight into what it might be like to be experiencing mid-stage dementia. Okay, next slide, please. Lovely. Chris Whitty.
Okay, that's me.
Haven't heard his name for a while, have we?
I'll be on it.
Level 1 dementia awareness training. The next session for this is on the 7th of October. So there's only a week or so to sign up for this if you'd like to take part in the level 1 training. It takes about 2.5 hours. Our head of training, Elaine Thorpe, delivers this. It's free. Again, it's all part of our B&M Care giving back and sharing knowledge with the wider community. I hope that you will find that useful.
Sorry, am I being a bit too?
No, that's absolutely fine. So Caroline said, reach out to us. You can look at our events page, reach out to us on our social media channels. You have got there my email address and Caroline's email address as well too. I have got another couple of questions come in. I'm going to just have a little chat to just see. Should someone with dementia be told that their partner is the one that has chosen to move them away as they no longer want to support them? Oh, that's a difficult question, isn't it?
Should a person with dementia be told their
partner is the one that has chosen to move them away as they no longer want to support them? I would think that was facing rejection would be a very difficult thing to do, wouldn't it?
And they probably wouldn't remember that, and it probably just gets relived.
Every time you tell them, it's like a new wound, isn't it? It's like telling someone that your husband's died. Every day you're going to relive that.
I suppose it's hard without knowing the whole situation, because there might be there's might be conflict there, or situation, or it could be just the loved one can't cope.
Could be.
So I would probably just use distraction, and and I wouldn't go down that rabbit hole with them, because it would only hurt.
It would only hurt again, wouldn't it?
Yeah.
Okay, everyone. If there's more questions, you can reach out to Caroline or me on those email addresses. But thank you for your time and attention today. I hope you found the webinar helpful. We will email you an evaluation form for along with the recording, and also a CPD, certificate of attendance. Your feedback is really important to us. You can tell from the presentation we're not absolute experts in presenting. We have a laid back approach, but so your feedback is really important to us because it helps us grow the next webinar on the group of people. I'd love to see you on one of our up and coming events. So that's it for today from us. Thank you for attending. We will say goodbye, and we will sign off. Thank you very much.
Bye.
Take care, everyone.